Hi, everyone, and welcome to the show. We are live in El Paso, Texas at the CLI-F Conference, and Dr. John Phillips is off on assignment saving those piggies somewhere in the world. I think right now he might be on a mission to Guatemala, so he couldn't get any sort of service. So we are going to have him join us again next week. Meantime, I am joined by Lorena Henderson with the CLI-F Conference, and we are live again in El Paso, Texas. I just got off stage. I had the amazing opportunity to present at this conference and share the patient's experience and the importance of advocacy to our audience of about 150 people. So it was really exciting. Do you want to tell us a little bit more about this conference and why it's so important to saving life and limb?
Sure, absolutely. We've founded this organization about a year and a half ago and found that there was a huge need for education and for just expanding the knowledge base of peripheral artery disease, critical limb ischemia, and really finding the right physicians and the right teams to help these patients to save limbs and save lives. And so this is our initial attempt. This is our second annual conference. We are reaching out to the entire Southwest region and just educating physicians, nurses, anyone who is in the community, in the medical community, to come and be part of the team. This conference is multidisciplinary. We have interventional physicians, cardiologists, vascular surgeons. We have podiatrists. We have patient advocates such as Kym, and we're so honored to have her be part of our faculty this year. This year, we were honored to have Dr. Jihad Mustafa, Dr. Jay Matthews, Dr. David Alper, and Dr. John Bonilla come in, as well as Dr. Sarah Rose from Mass General. Just an incredible group of physicians who came in to share with us and join our incredible faculty. We have amazing, very talented, passionate physicians in El Paso who have committed their careers to saving limbs and saving lives. And so their mission and our mission as an organization, the Limb Savers Society, is to educate, to help patients, to create advocacy. And so we're really learning a lot from Kym and want to join in her mission as well. And I think we just need more organizations like this. The more we educate, the more we can help patients learn about what we need to do to get them the healing and get them back to their quality of life.
Something that I think is really important for patients to hear. You and I had lunch yesterday prior to this event, and you just poured out your heart about why your team started this, and the reality of, here are patients. There are 4 hospitals in this area, and while one hospital on one side of town is saving limbs and has this amazing shared decision-making experience amongst limb savers and people dedicated to exhausting all efforts to saving life and limb, and then across town, patients who either choose not to travel across town, which is literally less than an hour all the way across El Paso, or those patients just don't know that there's limb saving options across town. These patients are getting amputated, whereas across town, there might be a limb salvage program, which there is, that could give them the best chance of staying on 2 feet.
Absolutely. We have been honored to have and create over the last 8 years one of the country's only JACO certified peripheral vascular center of excellence here in El Paso at the Hospitals of Providence Memorial Campus. And unfortunately, across town, there are multiple hospitals that don't even do the minimal to even try to revascularize a patient or to treat these patients, to try to see if there's anything that can be done other than primary amputation. And so there's a lot of work still to be done. However, in the last 8 years, I think what we've done at this hospital and in the community has reached the entire community. As a whole, the community knows to send their patients to this hospital primarily for, with this patient population, but you have patients who will present to other hospitals. And so there's a lot of work to do to try and get these protocols and these policies and get this type of treatment to be equal in all hospitals, because it shouldn't be that amputation lottery that we have still in many hospitals across the country. I think there's a lot of work to do.
And so far, I mean, you have all of these physicians and clinicians from across the area, whether they're in podiatry or whether they're in vascular or even in pain management. We're going to get to, Dr. Rivera, Efrain Rivera, in just a moment. He's sitting alongside me, and we're going to talk about chronic pain when it comes to vascular and beyond. You have all of these different doctors and clinicians here. Have you heard anything thus far? We're now halfway through the conference where people have had any sort of aha moment, any sort of moments of inspiration or impact thus far in the morning?
I think honestly, the most amazing, every presentation has incredible information in it, and it was really impactful to hear Dr. Mustafa share what he's been through and how he got to where he was starting 15 years ago. And so he's been an inspiration and mentor to us. So that was an incredible presentation, and just what he said about the second opinion. These patients have to know that it's okay to get a second opinion, and it's necessary for patients to be able to be their own advocates, and for us as clinicians to be able to help patients through that process. I think there's a long way to go with physicians as a whole to understand this process and understand that this is about the patient and what the patient needs, and that we need to leave our specialty at the door, as Dr. Mustafa says, and just take care of the patient.
One of your speakers that's here is Dr. David Alper, and he's a retired podiatrist, but on every single board, I think, of directors across the industry, including the American Diabetes Association on their board of advisors and the American Podiatric Medical Association, et cetera, et cetera. But speaking here today, one of the things that he said, and he wants patients to understand, is that a second opinion is so important. And he said, if a doctor is not okay with you getting a second opinion, they're hiding something. There's something about them that you have to run, because most doctors, and especially the advanced skilled doctors and the ones that are confident and have conviction in their care and their offerings, will say, you know what, you need to do what's best for you. I recognize different doctors have different approaches, different tools, and different techniques and different philosophies. And so go ahead, get a second opinion. And you know what? Bring that information back to me. Maybe I'll learn something as well.
Right. And again, it's about the patient. And so I think as we not only teach patients to seek these second opinions or to seek what they need for their care, we need to teach them also to be advocates for themselves. Because I find that patients will take an opinion, will take a word as basically law, and they will just go away. Or sometimes they won't even go follow up with their appointments. As you said, you had a patient that you had to basically walk into the office and get the appointment for them. So it's really important to teach them about being self-advocates and having their families be involved in getting the care that they need as well.
So important. And if they want to find out more, or people want to participate in maybe next year's conference or any other events throughout the year, is there a website or anywhere they can go to find more information?
There is. We have a website, cliffconference.com.
You are listening to The Heart of Innovation with Kym McNicholas, live from the Cliff Conference in El Paso, Texas. We will return after these messages. Don't go anywhere.
Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the show. We are live in El Paso, Texas at a limb salvage conference featuring all kinds of doctors, from podiatrists to vascular specialists to pain management specialists as well. Pain management is such a popular topic in all of our network because pain is a reality when it comes with chronic illness, and the toughest part of the chronic illness, which can lead to anxiety and so much depression, because pain can really, really weigh on you. You don't get enough sleep at night, and then, your exhaustion just magnifies it so much. So we're going to get into the pain. We have Dr. Gary Grindstaff. He is a podiatrist. He's also here at the conference. And we have Dr. Efrain Rivera, who is a pain management specialist, and I'm sure he's going to be quite popular during this entire broadcast. We'll probably have a few questions that might come in from our live studio audience from around the world. But I want to get started, here. I think, before a patient ends up on your lap in pain management, when it comes to especially vascular, they end up frontline. The person has a wound possibly, or they have pain in their foot. They're sent from the primary care to a podiatrist, correct?
That's correct. We see these people on a daily basis. They present the most common presenting complaint is pain. It's not that even necessarily that they have a wound or that they have tissue that's about to ulcerate. I've had people come in with a gangrenous toe and, oh, why are you here? And they say, well, my foot hurts. They don't even tell you that their
No.
toe is turning black.
No.
And so we see them very frequently first. We see them oftentimes that have back problems, that is they're getting pain in their foot and they think it's their foot that's the problem.
Right.
And as we mentioned here at the conference many times about their venous stasis, their ulcers or pain can be from vascular problems.
Right.
And so we end up seeing them first, and as we move through the process, Dr. Rivera gets involved in treating these people's chronic pain.
Yeah, you brought up a really good point when it comes to the back issues. And I learned from with my dad, we went to the podiatrist and he was feeling some numbness in his toes. And the doctor had a chart up on his wall of the leg and the foot. And you could actually see which nerves actually led to foot pain. And I thought that was fascinating. I wish that every single patient had a chance to look at that and be able to help them understand what's vascular versus what might be stemming from a spinal problem or sciatica.
Well, one of the biggest failures of medicine is people that come in with pain or complaints such as this, and oftentimes they're seen and no one even takes their shoe off.
Oh, yes. And that's where you mentioned that, they don't tell you that they have a gangrenous toe. They're saying their foot hurts and no one ever says, hey, take off your socks.
I mean, I'll never forget when I was a resident. I remember having a gentleman come in at LA County Hospital, and he had gangrenous toes for months. And I asked him, I said, well, didn't you think something was wrong? And what made you come in now? And he said, well, my wife made me come in and she said it was smelling.
Oh, no, we're talking about wet gangrene at that point. I had a friend of mine that was in a case and in Utrecht in the Netherlands, and the patient came in with a black bag, literally rubber banded and tied on to her leg. And it was like, how do you wait until it gets to that point? And the patient said, well, I have this bag on because my leg smells. Well, at that point, you're guaranteeing amputation. Why didn't you get in sooner? How is it that some of these patients do end up waiting?
Well, in the diabetic patient's case, frequently they have no pain.
Right, because of the
neuropathy in their leg and foot, they have no pain. And the way they think of things, and pain is our friend, actually. I mean, because it warns us that something is wrong. And when there is no warning, people can have horrible things going on. And if it doesn't hurt, they think they're okay. And I mean, this is a daily experience that we see here in El Paso, is people with severe neuropathy. I had a patient who, during the hot summer here, on one of these flat roofs with tar paper on it, he had a swamp cooler that didn't work, and he decided he needed to go up and fix it. Walked up there without his shoes on and just socks, and second-degree burns on both of his feet. Wound up losing a leg because of his neuropathy, and he didn't even know that something was wrong. And it's a very sad story.
And it brings us to the importance of making sure that patients, if they have any sort of diabetes, type 1 or type 2, starting at age 40, making sure that you go in and you say, hey, doctor, check my feet, check my pulses. I can't feel. Recognize that you have the neuropathy and make sure that you have someone else that is checking your feet on a daily basis and making sure they're checking the pulses.
This is vitally important.
And so do you find that, a lot of these patients, they end up coming in late, and so they're a toe stub away from amputation, and by the time they end up with a wound, especially, the tissue's already dying, the nerve damage is already there, and so while a doctor might be able to open up some of the vessels, it doesn't get rid of all the pain.
That's very common. By the time they have serious wounds, usually they could have infections that have proceeded into the bone, and they could need surgeries and even minor amputations. But all these things, even when we say we amputate a little toe,
Mhm.
it changes how you walk. It
Yep.
changes the pressure on things. And now you start developing problems elsewhere. And I think with neuropathy, one of the big things that people don't realize is that not only does the skin lose sensation,
Mhm.
but the little tiny muscles in the foot are paralyzed because there's no innervation to them, and you start to develop deformity of the foot. And then the deformity leads to pressure, which then leads to skin compromise and ultimately ulceration, which then can become infected. And then we get into the hospitalization and all the problems that we see on a daily basis.
Thank you so much, Doctor. We really appreciate your perspective on that. And of course, we're going to get into more of what you can do for pain relief in these situations in just a moment with Dr. Efrain Rivera. Welcome back to the show. Again, we are live at the CLI-F Conference, a limb salvage conference in El Paso, Texas. Dr. John Phillips is on assignment on a mission in Guatemala, possibly saving more piggies around the world. Meantime, I am joined here by Dr. Gary Grindstaff, and he's a podiatrist, and we have Dr. Efrain Rivera, who is a pain specialist. Prior to the break, we had been talking to Dr. Grindstaff about, just the problems with diabetic neuropathy, overall neuropathy, and the fact that we can have this domino effect, right, with the patients who end up having ultimately an amputation or some sort of change in their feet or their toes, and they end up moving off balance. And then in comes, right, the referral to the pain specialist. And then what do you do at this point, Dr. Rivera?
Well, the first thing you have to do is actually get a whole history about the patient's medical problems. And I usually spend about an hour, believe it or not, getting all the information, cardiovascular, pulmonary, diabetes, high blood pressure, everything that I can get from the patient in terms of their history. And then after we do that, we say, okay, where are you having pain? And then they tell me where they're having pain. And then let's say, for instance, Dr. Grindstaff, he saw the patient, he amputated the foot or he amputated several toes. Then the patient comes in because he's saying, oh, I'm having back pain. Okay, so that's a clue because I know that, like doctor mentioned, when you have some of your toes are missing, you're not gonna walk like a normal person. You're gonna either walk with a cane, you're gonna walk a little crooked, you're gonna walk with a limp, and then your pelvis is gonna be off kilter. Then you may wind up having pain in your knee, pain in your SI joints, or pain in your lower back.
Do you
Or
ever
pain
find
in
it's
your
like
hip.
this domino effect, right?
It's
We
like a
always,
domino effect,
right?
correct.
It seems like once you have one thing, it just this cascade of one thing after another, after another.
And the thing is that is correct. So what happens is these people already are older people, so they've already generated some degenerative disease throughout their joints. And so they're more prone to having pain in those joints if they're not walking like a normal person. And they're not going to be walking like a normal person after they had their toes cut off. So then they come to me for pain. And so I have to evaluate them really good, get the history and physical, and then we sit down and we talk about, okay, what surgeries have you had? And back surgery, any kind of other spine surgery. Oh, you had foot surgery. Oh, okay, let me take a look at your foot. Okay. And I do the entire physical exam like any other pain physician would do, from head to toe. And so we find out, okay, well, you're walking crooked because the doctor amputated your foot. Okay. And so now let's see where you're having pain. Are you having pain in your SI joints? Are you having pain in your lumbar spine, your cervical spine, your hip, or your knee? And so I examine all these joints. And then they'll tell me where they're having pain. And then we can make a plan as to what medications I can give them and what injections I can give them and whether I can do radio frequency to certain parts of the joints to help them get longer pain relief.
It's interesting because that's one of the top complaints from patients who have peripheral artery disease, which is those blocked arteries and mainly the legs, is that they can no longer get access to a lot of pain medications. Gabapentin doesn't cut through some of this pain. Tylenol doesn't cut through most of the pain. And so they just have no other options. But you're saying that if they get a referral to a pain specialist like you, that you might have additional options for them.
Well, we do have additional options. I mean, we have more higher potency, longer acting narcotics. Well, they're narcotics, they're opioids, and they can help the patient in the long run. The thing is, they always ask me, Doctor, am I going to get addicted with this medication? Well, all the medication I prescribe are addictive. The answer is, I don't know. Do you have an addictive personality? If you do, then you'll probably get addicted to them. But if you don't, then you probably won't. But we don't know until we give you medication and see how you react with the medication. So we have stronger medication than, say, Tylenol number 3, Tylenol number 4, which is usually prescribed by some of the surgeons. And then when they come to me, they say, you know, doctor, that really wasn't working. It gave me relief for 1 or 2 hours. Okay, not a problem. We'll start off with some hydrocodone or oxycodone, and usually that takes care of it. And if that doesn't take care of it and they're having a lot of pain, there are other things we can prescribe.
Right, but those are really temporary because ultimately those are just something to get you through, right? They're not supposed to be a long-term solution. They're supposed to be a step towards getting you to therapy, getting you what you need in order to mitigate the source of that pain.
Okay, the answer to that is yes and no.
Okay.
Because yes, it can help you with the acute problem of pain, but it will not help you with the chronic problem that you may have developed in your knee, your pelvis, your SI joints, or your lower back, because you already had degenerative disc disease or arthritis in your spine, and now you have pain. That's another issue. So yes, we can give you pain medication for the acute problem, but then we don't know if you're going to have chronic pain from, degeneration of your spine or your pelvic joints and stuff like that, your knee, your hip. We don't know. We'll know after you get rid of the acute problem.
Which is really tough. And there are also natural ways. Prior to this broadcast, you and I were talking about some natural supplements that can make a really big difference for patients with pain and inflammation.
Yes, that is true. I personally advise my patients who are my pain patients that they may want to take omega-3. And I ask them, are you allergic to fish? No. Well, you may want to try omega-3. And the reason being is because it does have some good beneficial effects. On what? Okay. It's good for your heart. It's good for your brain. It's good for your kidneys. It's good for your joints. Those are some of the already benefits that are already known. And so a lot of my patients don't even know that those are some of the benefits. So I tell them, why don't you start taking some omega-3? And then they'll say, well, how much do I have to take? I go, well, I mean, you can take, I recommend you buy omega-3, 1,000 milligrams, and you can take 2 to 4,000 milligrams a day. Okay.
You're listening to The Heart of Innovation here on KTRB Studios, 860 AM The Answer, with Kym McNicholas live from the CLI-F Conference in El Paso, Texas. We will return after these messages.
Hi, everyone. Welcome back to the show. We are live in El Paso, Texas at the CLI-F Conference. It's a limb salvage conference. I am here and joined by a podiatrist. We have Dr. Gary Grindstaff, and we also have a pain management specialist, Dr. Efrain Rivera. And right before the break, Dr. Rivera, we were talking about natural ways in which people can improve inflammation in the body and possibly reduce pain. You were talking about omega-3s, and you were just getting ready to get into some of the benefits of the omega-3s and how to choose the right omega-3 for you.
Okay, so my understanding and my belief is that omega-3s actually work. They do have a good benefit. However, they're not an acute type of medication. It's not going to change anything in 1 or 2 weeks. It's ingestion of a medication over a period of months that will have a beneficial effect. What's the beneficial effect, doctor? Well, you're going to have less inflammation in the arteries of your body, one. You're going to have joint relief by improving the joint spaces, two. You're going to have the coronary arteries. It's going to be beneficial for your heart. Your coronary arteries are going to do better because there's less inflammation in your coronary arteries. Same thing with your kidneys, and same thing with the arteries of your lower extremities. So they're good for a lot of things. And one other thing, they do lower your triglycerides. And so when they lower your triglycerides, usually your cholesterol comes down. So I've seen it myself where patients are on lipid lowering medication, and I say, look, let's give it a try. You don't need to be on this because you're getting a lot of muscle pain with these lipid lowering drugs, because that's one of the side effects, myalgia, muscle pain. So we take them off, we give them high doses of omega, and 3 months later, they're not having the muscle pain, and their cholesterol is less, and their triglycerides are less. So bingo. Okay, so that's a win.
And
You
so,
know, I could testify somewhat to that with the statin drugs. I've taken
You got muscle pain.
I've
Yes.
taken a Storvitatin for years,
Right.
and not only do I have muscle pain at times,
You can
cramps.
figure it out.
Yeah.
You can figure out why you have muscle pain.
Yeah, at first I didn't know why I was getting these cramps,
Right.
and you know, like people asking, my patients used to ask me all the time, doctor, why am I having all these cramps? And I'll ask them if they're on cholesterol lowering medication. Sure enough, most of them are. So it's not an uncommon effect.
Yeah, I know. I've seen that with my patients. And another medication that is prescribed rampantly across the diabetic population is metformin.
Yes.
There are people that take high doses of metformin, 1,000 twice a day, 2,000 twice a day, stuff like that. And I'm their pain doctor, and they're saying, doctor, I'm having pain in my shoulders, I'm having pain in my legs. And I go, well, let's see your medications. I look at their medications, they're on metformin. And I say, metformin may be the one that's causing you all the muscle pain. And sure enough, you know, with the cooperation of their family doctors, can you put them on something else? And let's see if the muscle pain, they get off the metformin, and within a month or two, they don't have the muscle pains anymore. So that's another medication that causes, myalgia, muscle pain.
Well, and we see people all the time also that present in our office with earlier forms of diabetic neuropathy where they have burning pain in their feet, and they're usually have been taking gabapentin prescribed by their family doctors. Almost all of them will say, at first it helped, but now it's not helping.
Okay, so that's very interesting. Diabetic peripheral neuropathy in diabetics. All right, so I have patients like that, and across the board, some will be on gabapentin, and they're okay with that. They're on moderate to high doses of gabapentin, and they're okay with the peripheral neuropathy type of pain, pins, needles, and some pain, but they're controlled with the gabapentin. And then on the other side, I have people that are on gabapentin and pregabalin, and they're still having the diabetic peripheral neuropathy. It's not spinal pain. It's not lumbar nerve pain. It's peripheral neuropathy. And so I say, okay, so let's see what we can do. All right. So the first thing I do is let's see what dose you're on. I max them out on their doses, and if they're still having pain, then I say, okay, the FDA 2 years ago approved a spinal cord stimulator for diabetic peripheral neuropathy. And so that is a suggestion. And so we talk about that and see if they want to go through a trial and have a permanent placement of a spinal cord stimulator for the diabetic peripheral neuropathy. Sometimes they do and sometimes they don't. But at least they got that option. And a lot of people don't know that.
Yeah, and that's why I brought this up is that we get patients with severe burning pain, tingling, numbness, and they don't walk, and they usually will have some level of PAD on top of this, and they don't walk because of these uncomfortable sensations. If they're not being managed well with gabapentin and Lyrica, then doing something like you say of talking about putting a spinal cord stimulator in there is a viable option for some patients.
There's also a lot of high risks, especially for patients with a lot of comorbidities, though.
Yeah, that can be true. But one thing that we didn't talk about was prior to doing that invasive spinal cord stimulator, there are other medications that came out recently where you can apply a film over the dorsum of the foot and the plantar aspect of both feet. So you have like two films, one on the top, one on the bottom, and there's a medication called Qutenza. Okay, Qutenza is a medication that is 8% capsaicin. Okay, chili powder.
Oh,
Yes.
really?
Chili powder. Chili powder is 1%, right? Over the counter at Walgreens. But this is capsaicin 8%. Brand name Qutenza. If I try to get that for my patients, and a lot of my patients are Medicare, insurance company ain't going to pay for it.
That's true.
Because it's too high. And the cost of the medication is very high. But rarely do they approve it, and then we can apply it to the patient once every 3 months. And they get pretty good relief of their pins and needles and pain in their feet, And so that's a good medication. The thing is, it's very hard to get because nobody wants to pay for it.
Well, that brings us into the whole issue of your ballywick here of people that need something that is not going to readily be covered by their insurance, and they may have exhausted all other options, and yet they can't afford to do something simple like putting the capsaicin on there. They can't, and so they just don't, and then the downward spiral continues.
You're listening to The Heart of Innovation with Kym McNicholas live from the CLI-F Conference in El Paso, Texas. We will return for our final portion after these messages. Don't go anywhere.
Hi, everyone. Welcome back to the show live in El Paso, Texas at the CLI-F Conference. It's a limb salvage conference. I'm here with a podiatrist, Dr. Gary Grindstaff, and also a pain management specialist. We have Dr. Efrain Rivera, who is here with us. And before the break, we were talking about the fact that there are a lot of insurance companies that may not cover, some of these options for patients. But I'm, curious, when a patient comes to you and they say, okay, we're going to try this, how often does the patient not come back to you if something doesn't work for them? Or do you even know a reason why a patient might not come back? Because we have patients that come to our group, they're like, oh, I've tried this, oh, I've tried that, my doctor doesn't listen to me, there's nothing they can do, and you're none the wiser.
Well, do we have patients not come back? Very rarely. The problem is that they're in so much pain for whatever reason that they usually go back to their pain doctor because he's the one that has the medications to help them, and he's the one that has the injections, the procedures to help them. And so they rarely do not come back. They usually come back.
Only the ones that are in our network don't go back to the pain specialist.
So, well, I mean, I've been lucky here in El Paso, Texas.
Well, you're really kind. You seem like you spend a lot of time to really listen to them, which, before we close out, I want you to tell everybody what are the criteria that people should use to determine if a pain specialist is right for them?
That's a very good question. Now I can give you generic answers to that
We like spaghetti.
because
Good
then
ones.
I don't want to piss off my fellow pain management doctors in El Paso, Texas. But anyway, so the answer to your question, just like any other physician, if you go there and you feel the office is a nice place you'd want to be and sit and wait for 30 minutes to an hour, because sometimes that's what it takes, and the staff is treating you nicely and they're not always in a bad mood or anything like that. One thing, the front staff, the medical receptionist, the intake people, they have to be nice to the patients regardless of what office it is. And so that's one of the things you may want to, and if they're not nice, the patient usually never comes back. Okay. And then the doctor is so important because he has to sit down and listen to his patient. When I was in med school at Baylor College of Medicine, my professor in history and physical taking, he says, Efrain, if you sit down and listen to the patient, 75% of the time, the patient's going to tell you exactly what he has. And it's just like a lot of times in today's modern medical society, doctors don't spend enough time with their patients to listen to what they have to say. So they're just treated like another number. I try not to do that because that's not what I learned in med school many years ago. So I try to sit down and listen to my patient and try to figure out the best approach to their pain. Now, when I finish, I've had a lot of patients say, "Doctor, nobody ever examined me like that. Doctor, nobody ever that much time to listen to me." And I go, "Well, that's because I'm an old school doctor. And a lot of doctors don't have time. I have time. I don't."
And that I think is a really good indicator. If you're going to choose a physician who is a pain doctor or any other doctor, is that first consult is so important. If they stop and listen and you really feel like they're not only listening, but they're truly hearing you.
That is correct. If you go in and the doctor spends 10 minutes with you and didn't really listen to you, you don't want to go to that doctor.
Are there any other indications that we have about 30 seconds here? Any other indications in terms of the options the pain specialist might have for that patient that would be indicative of whether or not they're the right pain specialist for that patient?
Well, I mean, the patient has to be comfortable with the demeanor of the doctor. The patient has to feel comfortable that he can trust the doctor. The patient has to feel comfortable that he's in the right place for pain management. And if the answer to those questions are no, I don't feel comfortable, I don't trust the doctor, and I don't like this place, then don't go there.
Great advice. Thank you so much. We really appreciate you. Dr. Efrain Rivera, he's a pain specialist over here at Texas Tech in El Paso, Texas. And Dr. Gary Grindstaff, thank you so much for joining us here on the show, live in El Paso, Texas at the CLI-F Conference.